Prof. Edmund. Dr. Lee, can we start now?
Okay.
Yes, sure.
Good afternoon, everyone. Welcome to the weekly webinar organized by the College of Physicians Malaysia. We are in the month of September, and this month we'll be focusing on infectious disease. We are currently in week 2, and today's our topic will be on meliodosis. We are very fortunate today to have us with her, the chairperson, Prof. Dr. Edmund Ong, and also the speaker, Dr. Lee Kok Soon. Without further ado, let me introduce Prof. Edmund L.C. Ong. He graduated from University of Newcastle Medicine School in UK and was further trained in the general internal medicine and infectious disease and tropical medicine in the UK. Subsequently, his research mainly has interest in the field of opportunistic infection, evaluation of anti-infective agents, clinical epidemiology, and innovation in healthcare quality improvement and clinical audit. So he is also a principal investigator and collaborates in numerous research projects, including HIV, tuberculosis in Nigeria, South Africa, and Myanmar. So he is also an examiner for both undergraduate and postgraduate examination, including MRCP, diploma in HIV medicine, and MMed qualification. Okay, yeah, he's currently the honorary professor and on consultant infectious disease for Newcastle University. Without further ado, I pass the chair to Prof. Edmund.
Right. Thank you very much for that introduction, Dr. Liu. It's a pleasure for me to be here this afternoon, and especially to introduce Dr. Lee Kok Soon. He is an infectious diseases and internal medicine physician, currently based at Hospital Tunku Ajafa, Seremban, and he's been there now for well over a year. Now, following his graduation from University of Malaya in 2009, he spent about over 10 years in medical service in East Malaysia, in Sabah, serving and the communities out there in Kota Kinabalu, Kudat, and Kanaka. He obtained his MRCP qualifications in 2016 and completed his ID training in Penang General Hospital, Hospital Sultana Amina in Johor, where I first met Lee Kok Soon. And he successfully also completed a year of MTI training in the United Kingdom at a big regional center at North Manchester General Hospital. In 2024, he actually completed the Global Health and Humanitarian course organized by Doctors Without Borders, MSF, okay, and went on to obtain a DTMH qualification. He has obviously developed an interest in tropical medicine and HIV medicine. And I, without further ado, look forward to hearing his experience and his talk on meliodosis. Over to you, Dr. Lee Kok Soon.
Thanks, Prof. Edmund, for the kind introduction, as well as Dr. Liu, and big thank you to College of Physicians for inviting me to give this weekly webinar. So I will share my slides. If there is any issues with my slide, please do let me know. So can you view my slide in the full presenter or the full mode, or is at the presenter mode?
Presenter mode.
Sorry, it's still at the presenter mode, is it?
Yeah, correct. It's on presenter mode.
Okay. Is it better now?
Yeah, now it's full screen.
Okay. All right. So I'll move on to my presentation. So basically, the topic that I'm presenting today is about meliodosis, and it is also known as the great mimic. And this will be the outline of my talk. So I'll give a very simple case study, followed by introduction, a bit about microbiology, about meliodosis, epidemiology, transmission risk factors, clinical manifestation and differential diagnosis, lab diagnosis, treatment, which divided into intensive and eradication phase, a bit about adjunct treatment, case studies, and my list of reference. So I'll start off the talk with just a simple case study, which is also a real case presented in Hospital Tuanku Jaffa. So it's a 29 years old man who works as a security guard and newly diagnosed type 2 diabetes. He had history of a visit to Baguio City in the Philippines, and he presented to us with a neck lump, fever, night sweats for the past 2 months, and done IND of the neck abscess and was discharged home. And the microbiology passed, as well as the tissue culture actually shows a gram-negative bacilli. So in context with this talk, basically the diagnosis is fairly obvious. So basically for meliodosis, basically this disease is a name with 3 eyes. So a lot of people tend to forget the eye at the center. Then gram-negative bacteria known as Burkholderia pseudomallei and widely found in soil and fresh surface water. So endemic area includes our region, which we are residing in, Southeast Asia, Northern Australia, and South Asia, China. And majority cases, diagnosed cases are from Thailand, Malaysia, Singapore, and Northern Australia. And a bit about the morphology of the bacteria. So basically, usually the colony morphology is like a dry, wrinkled colonies with a bit of a metallic sheen. And also, it is also known as safety pin appearance type of bacteria. So why is it safety pin? As you can see, the photo that I quote from this paper, there's bipolar hyperintensity staining. So if you look at it, it looks quite similar to a safety pin. And also some added point would be it is actually considered as a category B bioterrorism agent or diseases. And this map basically shows you that we are basically right in the middle of the hotspot for meliodosis. And Southeast Asia region has been proven that the presence of meliodosis is rather confirmative, while other regions sometimes the evidence are still lacking, and there are certain countries which are absent of from the meliodosis infection. And next slide, basically I wanted to show you would be the prevalence of meliodosis in Malaysia. So these are some of the papers that I managed to compile. There are a few which are recently published, including the paper from Negeri Sembilan published by the Public Health. So I think among all the papers that I've referred to, so Kedah would be the highest prevalence among all of our state with the available data, with about 16 over 100,000 population per year. And this is followed by Sarawak, which this data was actually published by our ID colleague, Dr. Tony, back in, I think, 2022. And this is followed by Pahang, as well as Sabah with 6.1 and 4.97. And lastly, in Negeri Sembilan, the prevalence is about 3.1, which is a paper published by the public health physician, just recently published this year in the Neglected Tropical Disease Journal. And just for your interest as well, the first documented case of meliodosis in Malaysia is in 1913, which involved the lab guinea pigs and rabbits in our IMR institute. So what about in terms of transmission? So basically this the way that meliodosis transmit is actually very interesting as well, because it's very closely related to our environment and also our occupation. So how does it transmit? So it can actually transmit through percutaneous inoculation with exposure to wet soil or contaminated water with the soil that has the contaminated with the bacteria. And the second one will be inhalation through aerosolized bacteria during tropical storms or cyclones. And aspiration, ingestion of contaminated water, especially unsafe water, where it is not treated or unchlorinated. Very rarely, the transmission involves zoonotic transmission, lab-acquired infection, while other potential transmission would be breast milk, sexual transmission, perinatal, as well as nosocomial. Then in terms of risk factor, so as I mentioned before, environment exposure to soil or water in endemic areas, occupation-wise, such as gardening or hobby, gardening, landscaping, or rice farmer. and in particularly wet seasons, also history of traveling to endemic areas. So as we've seen more and more cases of meliodosis as well as published data out there. So severe or fatal meliodosis commonly occurred in those population patients with special comorbidities. So the most important one where they have the highest risk of getting meliodosis would be diabetes. And this is followed by hazardous alcohol use, chronic kidney disease, as well as chronic lung disease. Other condition which actually dampen our immunity, for example, like a malignancy, this thalassemia as well, also predisposes us to getting meliodosis. In terms of clinical manifestation, most infection basically they can be asymptomatic or subclinical, and severe disease usually occurs with risk factor. And incubation period can be 1 to 21 days with a median of 4 days, can even go up to 60 years. And symptomatic wise, 88% are acute cases, while chronic cases consist of about 9%, and the rest are latent infection with reactivation. And among all of the presentation of meliodosis, pneumonia is the most common clinical presentation. And just to illustrate how long this meliodosis can incubate. So this paper was actually published in 2005. It's a case report where, in this case, this gentleman, basically, he was a war veteran, and he was also a prisoner of war back years and years ago. And basically, he was involved in the construction of railway. I think one part of it was in Malaysia. So he presented to this hospital in America with a chronic unhealed ulcer. And this ulcer basically grew positive culture for meliodosis. And from extensive history taking wise, they've concluded that most likely this patient acquired this infection during his time as a prisoner of war by the Japanese during World War II. Then in terms of primary clinical sites involvement among patients, this data basically is from the Australian data in 2021. As you can see here, pneumonia is the highest among all of the clinical manifestation. And most often, pneumonia presented coupled with bacteremia, as well as very high rates of septic shock. And fatality among those group presented with pneumonia as well is also fairly high. And this picture or this slide basically just to summarize all the possible presentation for meliodosis. If you have a glance at this slide, you can see the same theme. It's all abscesses. So they, in terms of like CNS system, you can have encephalomyelitis, brain abscess. CVS, you have bacteremia, pericarditis, mycotic aneurysm. In terms of urinary tract infection, they can have kidney prostatic abscesses with acute pyelonephritis. And head and neck, as illustrated in the first case, respiratory system, pneumonia, pulmonary abscess, pleuritis, GI system, liver abscess, splenic abscess with paraintestinal mass, skin and soft tissue, skin ulcer, soft tissue abscesses, as well as musculoskeletal system with septic arthritis, myositis, and osteomyelitis. So next, I will just quickly show you some of the relevant imaging or some cases which I find that that are important for us to recognize. So like for common manifestation, so they can present with pneumonia with following symptoms. And X-rays, you can have a left upper lobe infiltrates. So when we look at this kind of X-ray, I mean, in our region, aside from meliodosis, we will be quite confused and thinking whether this also could be tuberculosis as well. Then the next picture also is a positive case of meliodosis. And however, this patient presented with chronic symptoms instead. And as you can see here, the trachea is actually being pulled over. And symptoms-wise, it was chronic cough, purulent sputum, and hemoptysis and night sweats as well. So this kind of presentation can also confuse us with other potential differential diagnoses such as tuberculosis. And in terms of other manifestation which involving the mediastinum, so this picture was taken from a case series also co-authored by Prof. Edmund and his team. And it was about a 52 years old gentleman who was actually traveled to Thailand and returned to the UK. And this CT basically shows you a large right apical loculated collection with extension into mediastinum. All right. Then the next picture I'm trying to show you is cutaneous meliodosis. So you can see here that there are lesions scattered all over the skin, because sometimes you do have patients who go into the jungle or to areas where they need to remove plantation, and some of them tend to not wear any protective clothing. And sometimes this bacteria can be directly inoculated to the skin and presenting as skin lesions, which lead to cutaneous melioidosis. Then for genitourinary presentation would be a prostatic infection or abscess, as shown in this picture, and other presentation as mentioned before, they can actually present with acute urinary retention as well. So back in when I was still training in Sultanate Aminah, my colleague, Dr. Chang, basically he basically was so fascinated with one of the cases that we encountered there, because the case was actually presented with a suprapubic swelling, and the case was referred to him, and he asked to aspirate the swelling, and it came out pus, and the pus culture subsequently positive for meliodosis. Then in terms of bacteremia, so sometimes it can be primary, where there's absence of localized site of infection, or secondary. And less common presentation are bone and joints, neurological involvement, parenchymal abscess or parotitis. And deep abscesses such as liver, spleen, kidney, and prostate are common presentation also. So this picture is another picture that I've taken from the case series co-authored by Prof. Edmund and his team. So it's a 38 years old gentleman who's also landed back in UK with an intracerebral abscess. Okay. Then in terms of hepatic meliodosis, they can be large, very dramatic, and with a large septated. This picture basically shows a large septated abscess in segments 6 and 7 with enhancing wall and septae. And it has also a honeycomb appearance with lung involvement. And next, I would also like to share this case that I find rather challenging, which I encountered in Hospital Kuala Pilar. So this gentleman is an end-stage renal failure patient. So he was diagnosed with meliodosis with a positive bacteremia. Then we actually completed 4 weeks of ceftazidime for him. If I remember correctly as well, he has some micro abscesses over the spleen. Then completed 4 weeks of ceftazidime. We actually discharged this patient with doxycycline, because in the ward when we started Bactrim, or the scientific name is trimethoprim sulfomethoxazole, he developed severe thrombocytopenia. So despite a few attempts for us to re-challenge, he cannot tolerate this Bactrim. So he went back with doxycycline. So he came to one of our physician MOPD follow-up in Kuala Pilar and complained of eye pain and redness. So the case was actually subsequently referred to our ophthalmology colleague, and they've done an intravitreal culture positive, and it is actually positive for meliodosis. So this case is actually fairly challenging, because we have completed intensive phase, and he is at his eradication phase using doxycycline. But despite on all those, the meliodosis actually happened again, and this time, unfortunately, it is the focus of the infection is at the eye. So this patient, unfortunately, was unable to salvage this eye and has to undergo enucleation. And yeah, it's a very unfortunate case in particularly. And this case also is long-term follow-up in Hospital Tunku Jafar, where it was managed by Dr. Ng, our head of unit back in Seremban. So this gentleman also developed a lot of deep-seated abscess and unfortunately also had multiple site of mycotic arterial aneurysm. So this part is the part where the artery is not able to, to be treated, as well as to be, underwent some surgical intervention, mainly because of high risk of bleeding and potentially complication from surgery. So in the end, after consultation with many different consultants, so we decided to put this patient on lifelong Bactrim because we are unable to achieve source control for this lesion. So if you, I mean, this patient in real life, if you're reviewing this patient, try and imagine this mass is basically just pulsatile in front of you. Then this picture is just to show you how does meliodosis infection progresses. So it can start in many ways, from percutaneous inoculation, from injection, and then from all this mechanism progressing to bacteremia and subsequently to more severe consequences. All right, so in terms of differential diagnosis, so it is very broad. So it can be community-acquired pneumonia caused by any bacterial or viral agents. It can also be tuberculosis, and unfortunately in our region, actually this is also very important for us to exclude. And other than that, staphylococcus as well as strep, soft tissue infection also is very important to be ruled out, and as well as disseminated MSSA, MRSA infection. NTM would be very unusual infection, but however, sometimes when you have multiple abscess, as well as difficult to heal abscess, so it's wise to consider whether this also could be NTM. And invasive Klebsiella pneumonia syndrome as well can present with a lot of deep-seated abscesses condition, which are very important for us to consider aside from meliodosis. So next, we will talk about diagnosis. So how do we diagnose meliodosis? So the gold standard is still culture. So if you can get a blood culture positive, then they'll be straightforward. But sometimes this is not the case, where your blood culture can be negative due to various reasons. And therefore, you have to look very hard and send many more cultures subsequently. So if, let's say, patient has respiratory symptoms, you should make an effort to send a sputum culture, urine culture as well, for those with genital urinary symptoms. And if the patient has an ulcer or skin lesion, try to get a swab culture. So sometimes also this may be challenging for us to secure, especially pus or fluid culture from drain abscess, because not all of us can have access to a subspecialty that may be able to help us to drain. So in cases where, like for example, in Kuala Pilar, so it's a bit difficult to have access to this intervention radiologist. So the service needs to be referred to centers in Klang Valley, for example. Okay. Then other culture that you may want to consider would be throat, rectal swab, chest X-ray imaging. Try to get a CT, thorax, abdomen, and pelvis for a more thorough assessment, and also ultrasound abdomen if you don't have initial access to a CT TAP. All right. So next, so diagnosis-wise, as I mentioned before, growth of Burkholderia pseudomeli from culture of any site is basically diagnostic. And in terms of the microbiology features of it, it grows very well on McConkey blood or chocolate agars, and Ashdown agars allows selective growth of B. pseudomeli. So in the area of MALDI-TOF, so MALDI-TOF basically is a very good system that now will make the diagnosis of Burkholderia pseudomeli even easier overall. And I'm going to mention something very controversial, so serology. So the serology for meliodosis, so sometimes it is really not reliable and not confirmative, especially in areas such endemic as we are, in this country. A lot of us may be exposed to meliodosis, but it doesn't mean that we have active infection. And sometimes low titers also can mean that actually we have exposure. So, and we should make a very good effort to get a culture diagnosis. All right. Then in cases where we have exhaust potentially all the revenue for us to get a culture diagnosis, we can consider this serology, which is strong positive, as adjunct to a diagnosis, especially in those culture negative with risk factor of meliodosis. So now very quickly, we move on to treatment. So in terms of treatment, broadly, we can divide it into medical or surgical. And for medical-wise, it will be intensive phase and eradication phase. And surgical, or rather, radiological intervention method, it is involving this drainage of abscess or pus. Then in terms of antibiotic resistance, generally, as a general idea, it is resistant to these following antibiotics, but we do not commonly use this antibiotic to treat this meliodosis. And the main therapeutic options include ceftazidime, carbapenem, Bactrim, doxycycline, as well as Augmentin in some certain cases. So some elaboration about intensive therapy. So initially, for intensive therapy, we should use ceftazidime. And for adults, usually it's about 2 grams 6 hourly for at least 14 days. Or meropenem is also a very important option, especially those patients with septic shock and require ICU support. Okay, I think this is a fairly important point where if you have a very unstable or ill patient, let's say that still waiting for intensive care support and all, so it's also wise to consider to initiate meropenem earlier. Okay, then when the patient is within this intensive therapy, we should send regular bloods. We need to monitor the renal function, whether there's any issues with a transaminitis, and as well as eosinophil count, mainly to make sure that there's no potential involvement of drug allergy. CRP is just to make sure that the inflammatory markers are coming down, and adjust your therapy if, let's say, patient develop renal impairment. So for situation where there's development of neurological meliodosis, osteomyelitis, septic arthritis, genitourinary infection, which involve your prostatic abscesses, skin and soft tissue, we should consider adding Bactrim for commencement of therapy. And how to add this? So we can consider gradual introduction. So this recommendation is basically was being recommended by the latest Darwin meliodosis guideline 2024. So in the exception which they've mentioned is except CNS meliodosis, means that you, in cases where there's CNS involvement, you should give full dose of Bactrim immediately. And in terms of duration of therapy, is really depending on what's the extent of the infection. The period actually can be as short as 2 weeks actually, up until 8 weeks or longer, depends the progress of the patient as well. So next, I'm going to show you some clipping from the meliodosis guideline, which actually you can download it in the web. So just to focus on, so you can see here skin abscess, purely skin abscess, actually you can only give like 2 weeks. And progressing downward is more and more deep tissue involvement. So those bacteria with no focus, actually intensive, you can go up to 2 weeks. Then those pneumonia cases, very straightforward pneumonia with no lymph nodes, no ICU admission, and negative blood culture, you can actually stop your intensive at about 2 weeks. And in terms of like more complicated pneumonia, you can stretch it up to 3 weeks. And those who require ICU admission or multilobar pneumonia with positive blood cultures, you can stretch it up to 4 weeks. So those that you want to consider the longest would be your CNS infection, and those cases which involve your blood vessels, which is mycotic aneurysm. All right, so as you can see here, so intensive is about 2 weeks, extending up until 8 weeks. And in terms of like eradication, is very simple. So generally, all of them are about 3 months. And those cases which you want to stretch your eradication phase, which is using Bactrim mainly, would be about 6 months for osteomyelitis, bone involvement, as well as central nervous system infection with blood vessels involvement. Okay. Then there are also many other points here which I think I can leave it to you to read. All right. Then in terms of a dosage, also these are the dosage that is being recommended. Generally is about for adult weighing 40 to 60 kg is about 240. So the Bactrim that we have doses here available in Malaysia is about 80 mg of trimethoprim. Then if you divide by that, then you get how many tablets, all right? So then you must remember to add on folic acid, mainly because Bactrim is an anti-folate agent, and to give this is basically just to supplement the patient. So this table is from the latest guideline as well. So you can refer to this table if you need some guidance on how to renal adjust your dose, especially for ceftazidime, meropenem, as well as Bactrim. All right, so just remember the creatinine clearance is usually this guideline is based on this Crocroft method. All right, so use that formula to count your renal function. Then they also are quite thorough in terms of the update of the guideline, where actually they suggested what should we do if there's problems with usage of Bactrim. All right, so like for example in AKI, so they will recommend us to renal adjust as per table or change antibiotic. And very commonly also we will have patient not tolerating Bactrim develop rash. So what can we do? So we can actually consider cessation or change of antibiotic or gradual desensitization may be considered. So in terms of like eradication phase, I forgot to elaborate just now as well. So what are the other options that we can consider? So doxycycline as well as Omantid, but these other two agents has higher risk of relapse and failure in therapy. So Bactrim is still the more preferred agent for eradication. All right. So other side effects from Bactrim are as follow, and these are some of the recommendations they've outlined for us to refer. So those with very severe skin reactions, such as Steven Johnson and Dress, they recommend that we should stop Bactrim. There's no exception to it. We must cease the antibiotic. All right. Then these are other follow-up or other complication from Bactrim as well. So I'll leave this for you to read at your own leisure. Then next, we'll talk something quite sort of like this therapy is really quite adjunct to the overall treatment. So if you read the latest guideline by Darwin, it is a policy for the Royal Darwin Hospital to use GCSF. So cases where in ICU or high dependency unit with meliodosis and septic shock, those population, they will consider using this. And how do they use it? So they will use fulvestrant 300 microgram IV daily. And to use or not to use, basically the decision is shared between ID and ICU team. And they normally use it for about 10 days, except in cases where there's coronary events or the white cell is more than 50,000. So what's the rationale behind the use of GCSF? So it is thought that this meliodosis infection causes this functional neutrophil defect. And by giving this GCSF, it is being ameliorated, means that this defect can be reduced by the GCSF. And why do I say that this is rather maybe up to debate or is still rather controversial? So we have like two study published, which I can find, it is also, I think, summarized in a lot of the reference. So this Thailand study group and Australian study group, basically the first author is the same person. So the Thailand study group shows the usage has longer survival, but there's no difference in mortality. However, in Australian study group, it shows a lower mortality with usage. And they have conducted this study in Australia study. I think they started in Australia first, and then subsequently they try to replicate this study in Thailand. However, it doesn't replicate the same result as they want in Australia. So the discussion was actually whether these confounding factors, where in the Australian group there's better ICU supportive care that actually lower down the mortality, while in comparison in the Thailand study group, unfortunately there's it doesn't show much improvement in terms of mortality, probably because there's not as robust ICU support care as in the Australian study period. So next, how do we follow up with cases like this? So we need to also arrange close clinic follow-up. So after patient completed intensive phase, and we follow the patient up with eradication phase. So we need to arrange a close clinic follow-up mainly because we want to make sure that there is no side effect from Bactrim. So what I recommend is you can give 2 weeks or 1 month follow-up with all these blood orders. And then when the clinic a patient appears in the clinic for review, you have to assess the symptoms, well-being, and then whether patient tolerance to the antibiotic. And most importantly, this tolerance is very important. So because you have to be very sure that the patient is adherent to the eradication, because if not, then one day the patient will return to you with a recurrence of meliodosis again. Then we can actually ask the help of our community health clinic to have a fast-track review of the comorbidities to have a better control of the diabetes. And don't forget to get a reassessment imaging, especially ultrasound or CT tap, to make sure that any deep-seated abscesses has positive improvement. Then decide your duration of eradication during clinic reviews and consider prolonged duration if the eradication, if actually the response is still require longer period. Then consider after you have stopped your eradication, you should consider yearly non-urgent follow-up on recovered cases. So what can you advise your at-risk patient? So some of the things that are very, very simple, but actually it is useful. So in terms of like personal protective equipment, so if let's say patient is working as a farmer, always go into has exposure to all the soils and all, so you can recommend them to wear waterproof shoes, boots, rubber gloves, okay? And then if let's say if they sustain any injuries, they should actually treat the wound promptly and thoroughly, and wear masks that covers the nose or mouth if using high pressure water hose. This is to prevent inhalation from all the aerosolized water, and can actually consider advise them to stay indoors during heavy storm, heavy winds, use safe treated water, as well as cut back on alcohol. So I think this advice slide actually I've gotten from the Darwin guideline as well. So I think we are coming at the end of the presentation soon. So this will be the case study that I wanted to show, which actually landed in Seremban Hospital. So it's a 59 years old Malay lady with type 2 diabetic, okay? Then the HbA1c is actually very high, it's about 10. Then her hobby is actually gardening, and presented to us with chest pain about 3 weeks, vomiting 1 month with epigastric pain. Also have some numbness. So this patient initially went to a private hospital and told to have splenic problem. So very vague, okay? Then discharged with oral cefuroxime and metronidazole and defaulted due to financial constraint. So from this history, you might think that, okay, so probably our private colleague is treating the patient for some sort of splenic abscess and trying to cover the patient with cefuroxime and metronidazole. Then because of financial constraint, the patient no longer went back to the private side and subsequently landed in ED and shows with following vital signs and admitted to medical ward. So the first impression that we gave this patient was actually a peripheral neuropathy due to uncontrolled DM and query splenic abscess. Then overnight, patient actually deteriorated. So very unfortunate. So go up the oxygen requirement go up to high flow mask, very tachypnic as you can imagine. Then the pulse rate is about 113 with high-grade fever. Then the patient was intubated and went for a CT tap. The main focus that I want you to highlight to show you is this. So patient has a very huge perisplenic lesion of about 9 centimeter. Then there's also a subcapsular collection at the posterior aspect of the spleen, which is about 3 cm. Then she was subsequently treated for septic shock with ARDS secondary to perisplenic abscess. and they started on meropenem in view of all this, very critically ill situation. So the case was actually referred to surgical team mainly because of the large splenic collection. So subsequently, we were alerted with this culture. So she was positive for meliodosis, Burkholderia pseudomeli, and as you can see, it's quite a pan-sensitive meliodosis. And this is a snapshot of her CT scan report, which actually shows you that the collection is actually coming up to about 9.9 centimeter. All right. Then the impression given was multisplenic abscesses with suspicious rupture and perisplenic collection and possible splenic vein thrombosis as well. So very dramatic kind of presentation. Then impression subsequently revised to septic shock secondary to meliodosis with splenic and perisplenic abscess. Then with all the proper treatment, meropenem and all, then proper source control, which was percutaneous drainage of perisplenic collection, patient was able to extubated and transferred to the normal surgical ward. And basically, she actually achieved blood culture clearance as well. And because patient was getting more and more stable, we were able to de-escalate the meropenem to ceftazidime, and the patient was started on Bactrim. And she was planned for ultrasound reassessment, and also subsequently, these are the plans for the patient. All right. So I think this case basically demonstrated to you that the patient can present to you in a severely very ill manner. And based on the patient clinical progress, you should revise and adjust your antimicrobial of choice. As you can see from septic shock, going to a more stable clinical picture, then you can actually safely de-escalate it to ceftazidime. All right. So then, so next, take home messages. So I think from all the example that I've tried to illustrate in this webinar is the clinical presentation for meliodosis is very varied. And we need to know our patients and the place of practice very well. So whether our region or our state, or the where the patient came from, or the way, or what the patient exposed to, predispose the patient to meliodosis or not. Then we need to consider risk assessment in each individual. And also, this is also slightly controversial, thought, which is whether you want to consider empirical treatment for individualized cases. Okay, so this is up to case-to-case basis, and I wouldn't recommend for all the cases that potentially that you've seen. And the main antibiotic or treatment option would be ceftazidime and Bactrim. And the usage of GCSF is still rather controversial with not a very firm data available. And we need to understand the duration and duration of treatment, especially intensive and eradication phase, based on the table from the Royal Darwin guideline that I have quoted. Adverse effect from therapy, which is actually can be potentially quite problematic, and arrange a proper follow-up, and also not to forget, can advise your patients for prevention, prevention measures. So this would be my references. So you can refer to some of the data, or any of the guideline as well is all listed here as well. So this will be the latest 2024 Darwin treatment guideline. Then these two papers are the GCSF paper. Then I thank you for your attention and time. And just to show you why I'm seeing a lot of meliodosis cases, so this is a picture where I've taken from Kuala Pilar in a nearby paddy field. Very beautiful, but the scenery is very beautiful, but just not to always forget where when there's beauty, there's always potential danger behind whatever you see. Okay, I think that's all for my presentation. So I will stop share my slide, and I'll possibly just open to any questions.
Yes. Thank you very much, Kok Soon, for such a brilliant overview of meliodosis, and I hope the audience, of which there are over 120 as its peak, of 120 people that have logged on. So there are quite a number of questions, and I'm sure that we will try to answer all of them. So therefore, okay, the first question, I think you have already answered part of it towards the last few slides. So may I know, is there any role for treating meliodosis empirically? So is there any evidence that if we treat with appropriate empirical antibiotics, it will reduce mortality, morbidity? So I think, Kok Soon, you have actually answered some of that question already in one of your slides. So would you like to just repeat that again, please?
Yeah, so this empirical treatment is really depends on where you practice. And just to quote an example that with a district hospital that I'm covering, Hospital Kuala Pilar. So we in that center we actually had very high cases of meliodosis. So cases with risk factor which I've mentioned, for example, like uncontrolled diabetes and presented with severe septic shock pneumonia, where you are considering covering for meliodosis, it is also possible to consider starting ceftazidime earlier and consider some sort of gram-positive cover on top of that. Then there's also this concern, I think all of us as a physician, as well as trying to make sure that we do not develop any antimicrobial resistance by overusing ceftazidime. So it's always to revise the patient diagnosis back. Like, for example, let's say if you have started empirical treatment by day 3 or to up until day 5, if you find that the cultures has failed to demonstrate that this is a meliodosis for you, perhaps you can consider revise and de-escalate. Maybe switch up the antibiotic from ceftazidime, or you can use Augmentin. But I mean, saying that as well, some centers actually prefers to use Augmentin itself, because Augmentin itself actually has activity against meliodosis. So then again, because I do not want to confuse you, because I want you to sort of like consider your practice based on where you are, as well as the advice based on the consultant who is, leading the infectious disease team in your respective hospital.
Excellent. That's a good answer. Okay. How long do cultures take based on your experience? Or yeah, let's take that question first before talking about serology.
Okay, how long does culture take? So usually if we have meliodosis, which is involving bacteremia, this is from my personal experience. So some of these cases where they are meliodosis, by 48 or 72 hours, usually the microbiology lab will inform us there's gram-negative bacilli. So actually this is a huge clue for you already. So just to mention 2 cases that we have actually encountered. So one in Hospital Sultanah Aminah, where I was trained with Dr. Masliza as well as Prof. Edmund. So the case was actually a severely septic shock patient with septic arthritis, severe pneumonia, and intubated in ICU. So the patient was admitted and then was alerted to have gram-negative. And the intensivist actually asked us for choice of antibiotic. So when I go through the patient profile, patient actually went into the jungle for some, plantation kind of activity, and then subsequently fell ill with pustular lesion over the knee and knee swelling, Then also patient has very uncontrolled diabetes. So in that particular case, with that gram-negative bacilli alert, I immediately started this patient on ceftazidime. And true enough, the confirmation actually came back with meliodosis. Then that's just to quote a second case where it happened recently in Seremban, but unfortunately the patient passed on because the patient was really severely ill. So the case was actually alerted to have gram-negative bacilli, and the antibiotic was unfortunately escalated to Tezo. So when but unfortunately we didn't really like go through the risk factor, risk assessment and all. Then by the time when it was confirmed to meliodosis and we escalated to meropenem, the patient actually went into severe septic shock already with a triple inotrope. So which sometimes we have missed the boat to initiate appropriate antibiotic to treat the sepsis or septic shock.
Yeah. Okay, is there any role for serology in monitoring response to treatment? Do we need to repeat blood culture for clearance?
Okay, in terms of that question, serology is I wouldn't recommend you to use serology to see the treatment response, but I do recommend you to repeat blood culture to ensure that there's culture clearance. This is mainly because sometimes we may think that the patient presents with purely bacteremia, and perhaps we have just performed a simple ultrasound, shows there's no collection. But if you repeat the culture and the culture is still persistent, so it means that there's some sort of foci that is hiding. And it's very important for us to really look hard and consider a more thorough scan, such as a CD tap, to really look for whether there's any hidden abscesses. So I think especially for male patient, prostatic abscess tend to be overlooked. So I think this will be so my recommendation is you perhaps should really consider getting a culture clearance, but not recommended for serology to recommend for
serology is play practically no role really in the context even for monitoring as well. Okay, and I think the next question you have already answered. Okay, in terms of I think the questionnaire surrounds like empirical treatment. Can we start treatment in patients with symptoms from 5 prevalent area not responding to any antibiotics? Staph aureus, IKS, TB has been ruled out despite no confirmatory growth. I think you have answered that. Okay, I think the next question is actually quite important. Okay, in the context that where has it gone? I think it's something to do with cotrimoxazole. Yeah, if a patient cannot tolerate Bactrim, would you re-challenge later or continue with the other alternative?
Okay, so in terms of intolerance, sort of like unable to tolerate Bactrim, perhaps we can see what is the clinical situation, in what way that the patient unable to tolerate. Like for example, if let's say patient develop skin rash, when we start the Bactrim. So what we can try to do is to gradually desensitize the Bactrim. So I mean there is no hard and fast rule how do you desensitize, but I would recommend you to have a look at this Massium HIV guideline for 2022, where they actually outline how do we use syrup Bactrim and then slowly progress to the tablet of Bactrim to desensitize the patient if, let's say, they have skin reaction towards Bactrim. So that is one context where you can slowly choose to desensitize them for skin complication. Like for example, if let's say patient unable to tolerate mainly because like for some certain reason like thrombocytopenia, perhaps you can also consider if let's say develop very severe thrombocytopenia, stop it first. And if the patient is still inpatient, you can slowly re-challenge also with lower dose and see whether the patient will tolerate or not. So in that case that I've shared, the end-stage renal failure case with complication of the eye endophthalmitis, unfortunately for that case, actually the patient was kept in the ward and we actually re-challenged second time of a Bactrim to see whether the patient can tolerate or not. But unfortunately, the patient developed severe thrombocytopenia again. And we actually, unfortunately, have to go with doxycycline. And the case that I show you is, unfortunately, as you can see, with doxycycline as eradication, actually, it causes this complication. Okay, so I will be very worried and concerned if the patient unable to get Bactrim as an eradication and go home with doxy and Augmentin as their eradication. And because of these two sort of like considered not a gold standard treatment. So we might want to prolong the duration of eradication. All right. So that is my sort of like my recommendation.
I think, yeah. And I think I can just emphasize about desensitization protocol for cotrimoxazole, widely practiced in the field of HIV. Cotrimoxazole is still, apart from meliodosis, is still the best drug to treat PCP, okay, and for prophylaxis, primary and secondary, okay, and the protocol is well validated, well researched, okay. I myself has actually done a bit of work on desensitization protocol on cotrimoxazole which is actually published in the Journal of Infection and actually within the Beaver treatment guidelines as well. Okay, so that is quite important to emphasize. And I think you have already also answered one question in cases with positive growth culture. Okay, if they completed intensive eradication treatment, is there a need to prove a negative growth? I think clearance blood culture is actually quite important, which you highlighted. I think the next question is the one that is challenging. Is there a role for PrEP medication in high prevalent areas, not for locals, but for people who enter these areas, for example, contractors who enter new areas, for infrastructure, soldiers who got into high prevalent areas for operational and exercises? Right, okay, this we can actually last for hours, okay, in the context of this for so Kok Soon, you first.
Yeah, I wouldn't want to talk about something that I've personally not, have not much of experience as well as good data to back me up. So I can try and do further extensive research on this. But so far I have not recommended any sort of like a prophylaxis for meliodosis itself. But I'm not too sure whether what about Prof Ed, do you
So
practice that?
this is actually a question that is unanswered. Okay, in the context is very much dependent on risk assessment. And the general rule of thumb is that no, okay, we don't actually recommend prophylaxis in that sort of context. We tend to actually making sure that patients, individuals are screened, okay, after they come back, okay, but particularly people, we have got a lot of expats. There are a lot of engineers that works in UK that spends 4 months out, okay, in parts of the world, and they come back, okay. So it's the employers that has got the obligation to actually do a health screening for all these individuals. And then when I was in UK, I tend to actually assess a number of those workers that have come back from abroad. And particularly if you work for MSF, okay, in your UK in the MSF, after your period of commission of work, okay, you undergo a fairly extensive medical after you come back from your period of commission abroad, okay, and so will be the soldiers, okay, the military doing exercises elsewhere, because we do have a lot of UK military personnel that comes over, particularly in the forests of Brunei and Sarawak, to do their jungle exercise, okay? And these individuals all can come back, all have got a proper medical assessment in that context. Yes, meliodosis is actually low on the risk, but there are loads of other things that can catch.
Yeah.
Okay.
A lot of other tropical infection.
Regarding the duration of intensive phase, a patient with bacteremia, meliodosis, and multiple splenic microabscesses, no other foci, stable, non-shock, how long to give intensive phase? Do we treat microabscess with prolonged duration up to 4 weeks or 2 weeks if the patient responding well as per bacteremic cases? And I think you have highlighted this in the Darwin guideline. Perhaps you just want to just emphasize it again, please.
Yeah, so those cases with deep-seated abscesses, including like a micro spinning abscesses, I think the duration is recommended by the Royal Darwin guideline is actually longer, so it can actually go up to 4 weeks. But I think since the patient is still inpatient, so if depending on your the hospital that you're in, if you actually when the patient is an inpatient and if you can get inpatient ultrasound assessment or even a CT assessment, then actually it will actually give you an idea whether the patient is progressing positively. Then perhaps that will also give you more confidence to convert the patient from intensive to eradication. So if you go through this guideline as well, when you sort of like nearing the period when you are trying to convert to eradication, so that is also the period where you can consider gradual introduction of Bactrim you know. So I think what they recommend, and even though the evidence is not very strong, mainly because they wanted to avoid long-term Bactrim or Bactrim intolerance. So what they recommend is you increase the dosage of Bactrim every 3 days up until the recommended full dose for the patient. Yeah, so I think go with the definition of the Darwin guideline, and from there you can roughly sort of like get a guide on how long do you continue the intensive, but whether or not to, you know, to truly like convert to eradication, perhaps consider getting a imaging reassessment to guide you in some way.
Okay. And one question which will be quite quick, wanted to ask if patient defaulted for eradication therapy, need to restart eradication therapy or just continue?
Okay, so perhaps also need to consider how, you know, how long the you know, when the patient default, and perhaps you also might need to reassess the patient overall again and see whether the prior presentation has it worsened. Like for example, if let's say patient presented with, you know, like a spleen or liver abscess and only completed intensive and probably just a month of eradication. So perhaps it's a good idea to reassess a patient overall again, get a imaging reassessment, and also you might want to consider admit the patient again and restart the intensive phase. So I guess the more direct answer to that question is individualize your approach to that. If perhaps like just a short sort of like short stop in follow-up, maybe just less than a week, you know, you might just want to continue your eradication, but those with longer period, you might want to reassess and consider, you know, reassessment.
Okay. I think the next question, you have already partly answered it. Okay, so if the patient unable to tolerate Bactrim, which antibiotic is better to use next? Doxycycline or augmentin? Any studies support doxycycline is better than augmentin or vice versa? I think you have answered that. Perhaps you just want to just emphasize the point again, Kok Soon?
I mean, to be honest, I don't find any very strong data saying that, you know, doxy is better than augmentin. One thing about starting patient on doxy, the problem that we encounter is patient find it very difficult to tolerate doxy, because doxy has a lot of GI side effect. They may feel nausea, they may vomit, you know, it will actually lead to very poor adherence. And for augmentin itself, you need rather high dose, you know, it's rather high dose, and there are many tablets that the patient need to take. So in my opinion, I would say that we sort of like should really try to use Bactrim, and those two options are the sort of like the last resort that we want to consider.
Yeah.
So that's my
The
take
other
on it.
thing that we see in UK with doxycycline is particularly individuals with light skin and blonde hair, they get a very high incidence of photosensitivity, particularly during spring and summer, using doxycycline as an adverse event, okay, apart from the GI tract symptoms, okay. So would like to ask, in cases of inoperable abscesses, how long should the eradication therapy be? If the reassessment scans do show micro abscesses, how do we plan the eradication regimen?
Okay, so if I understand correctly, so it's a deep seat abscess, splenic abscess, then during reassessment, there's persistent abscess. So we also encounter these cases during clinic follow-up as well. So my recommendation also to prolong it and reassess again with another imaging. So sometimes I would ask my colleague or my MOs to see the patient again. So continue the Bactrim, don't stop first. But if once we ask that, also we have to go through with the patient again, whether the patient's really taking the medication. You know, sometimes actually the splenic abscess is still there, mainly because patient is not adherent. Okay, once we have ruled out the issues with adherence, then you may consider to prolong the Bactrim. Then after that, get the ultrasound scan again, and only stop if, let's say, imaging has truly improved.
Yeah.
So there's no hard and fast rule. You can, you know, perhaps consider extending maybe like a 2 to 3 months depending on the situation.
Good. So last but not least, very quickly, it says that have you encountered a treated obese patient, I suspect patient with high BMI, empirically Venus augmentin 2.4 grams QID, or is it adequate to use 1.2 gram in that context?
Yeah, I mean, personally, I have not encountered such case before, but I can see the rationale behind that because of the, the PKPD involved in obese patient. And I actually personally don't have any recommendation that I can find, for 2.4 gram augmentin in terms of obese patient. I can try and look it up and get back to you later, but I have not personally. I don't have experience on that. I'm not sure whether Prof you have
I mean,
any.
one just have to be careful with such a high dose intravenous augmentin. It's actually the amoxicillin that can cause interstitial nephritis that one has to actually be careful about. So in such circumstances, you may want to actually perhaps reconsider using another alternative rather than augmentin. Ceftazidime, meropenem, may be a better choice, in that context. But yes, I think you got to be very careful about very high dose of augmentin. Particularly, it's actually the amoxicillin component, that is actually likely that could cause toxicity in that context. But wow, Lee, there's so many questions. You can see how interesting your talk has been, in the context
Oh
that
my.
there were
Okay.
all 100 people that logged on and 98 have stayed behind. So thank you again very much. I'm not quite sure whether Dr. Liu would like to say anything else. Dr. Liu, over to you.
Thank you. Thank you, Prof. Edmund and Dr. Lee, for this wonderful session this afternoon. I think we have come to the end of today's session. We will call it today a day today. We'll see everyone next week at week 3. We'll continue with infectious disease topics. Thank you, everyone. Thank you, Prof. Edmund. Thank you, Dr. Lee.
Thank you.
Yes.